Hemorrhagic shock. There's a hole in the bucket, dear Liza, with what shall I fill it, dear Liza, with what? One red cell, one plasma, one platelet. One red cell, one plasma, one platelet. The goal of hemorrhagic shock is to both fill the bucket and plug the hole. So your patient, there's a hole somewhere in the body, and the treatment is to make sure that you can fill the bucket faster than it's pouring out until definitive treatment, which is plugging the hole. So again, massive transfusions. We're talking about 10 units in 24 hours or 4 units in 1 hour, and the best transfusions with the best outcomes are when blood closely mimics whole blood. Your first round may be 6 packs of cells, 6 packs of FFP, and a pack of platelets. You can give cryo if the fibrinogen is less than 100, or empirically in your second round of your 1-to-1-to-1, which is usually, again, 6, 6, and 1. Large volume replacement is best through short and fat catheters, and your rapid infusion machines will run best with this. So a 16 gauge IV, peripheral IV, is actually preferable to a lumen of your triple lumen catheters. This is a picture to kind of see the different sizes and how they apply. So the other important part of hemorrhagic shock is, again, plugging the hole. So who is going to plug the hole? You have to think about the causes and source of bleeding for hemorrhagic shock. And more of the common ones are intra or post-op bleeding loss, trauma, large GI bleeds, and so there's some other listed here for postpartum or uterine hemorrhage, ruptured aortic aneurysms. The other thing is to consider CT angiography in the source of bleeding control. So if you can stabilize the patient enough to get to CT, you can see what they call a blush on a CAT scan to see where the bleeding is localized. And the big thing is to consult the appropriate interventionalist. So this is going to be your general surgeon, your thoracic surgeon, cardiothoracic GYN specialist, or IR. They can frequently go in with interventions to plug the hole. Additional considerations: hypothermia does lead to further coagulopathy, so keep your patient warm and use a blood warmer. Consider TXA and vitamin K. Depending on the patient's history, liver patients may need vitamin K. Older blood actually has a higher content of potassium, so thinking about that is that it may rise the K in your patient. You need to watch for that. Citrate and blood products binds to calcium, so you need to treat based on an ionized calcium point of care if you can. Also, don't forget that trending potassium, H&H, platelet counts, INR, and fibrinogen is helpful at point of care if you can, and there's something called a TEG and a ROTEM that can help you with that. Here are the references utilized that you can read for further information.